Our discussion today is epilepsy in the pregnancy. Basically, we will be highlighting few important questions which usually come in exam or in the Viva. These type of the questions may be asked related to the topic of epilepsy in pregnancy, especially from the RCOG guideline about epilepsy in pregnancy. Okay, so the first question that might be asked is that what is the recommended dose of the folic acid in these women? Okay, would you prescribe the usual dose of folic acid to these women who are already patients of folic acid when they come in the preconception period? So about this, I would like to say that all the women who are on antiepileptic, they should take 5 milligram of the folic acid, at least from the first trimester of the pregnancy, because it can reduce the incidence of the major congenital malformation. Okay, and it would be better if we prescribe it in the pre-pregnancy period, like pre-pregnancy folic acid of 5 milligram per day is very effective. And the lowest effective dose of the most appropriate AED should be used, okay, because exposure to sodium alphaurate and other anti-epileptic drugs, polytherapy should be minimized by changing the medication prior to pregnancy and also prescribing the folic acid. Now, how long should a woman be fit-free? That is also a very important question. Okay, when a woman comes in the prenatal period, she should be at least 9 months to 1 year fit-free. Okay, 9 months to 1 year prior to pregnancy she should be fit-free. Okay, now if a woman comes in the preconception period and she says that she has got fits in the last 3 months, so what would you advise her? Okay, the answer is that we would tell her that she shouldn't get pregnant until and unless she is fit-free for at least 1 year to be on safe side. Okay, and in that case, she would say what I do. So in that case, you can prescribe her the contraception. The choice of the contraception is very important. The first choice of contraception is that of the intrauterine contraceptive device. The second is that of Mirena, and third choice is Dumpa. Dumpa is depometroxyprogesterone acetate. Okay, so copper IUCD and Mirena and Dumpa should be promoted as reliable method of the contraception, as they are not affected by enzyme-inducing antiepileptic drugs. And women taking enzyme-inducing antiepileptic drugs like carbamazepine, phenytoin, phenobarbital, primatone, oxcarbazepine, topiramate, and aceclofenac should be counseled about the risk of the failure with some hormonal contraception. And women should be considered at the efficacy of the oral contraceptive like combined oral contraceptive pills, whether the transdermal patches which are rings, and these are affected when taking the enzyme-inducing antiepileptic drugs. Okay. And if the woman is non-enzyme-inducing antiepileptic drugs like sodium valproate, levetiracetam, gabapentin, vigabatrin, thiacabine, and pregabalin, she can take any type of the contraceptive method. Now, the question is that what is the role of vitamin K in the woman with antiepileptics? Okay, previously it was given after 36 weeks of registration, but nowadays, according to the current latest guideline, it is only given in the postnatal period. It means 1 milligram of vitamin K injection at the time of the birth. And the rule is that this vitamin K of 1 milligram intramuscular vitamin K prevents the hemorrhagic disease of the newborn. No role of oral vitamin K during pregnancy, and there is no evidence that vitamin K in women with antiepilepsy reduces the incidence of the PPH. Means there is no role of. Now the question is that if a woman is already on antiepileptic drugs, what would you recommend in antenatal period? What would you say that whether she can continue or not? So that depends upon the patient. Okay, means if the patient is already controlled on the monotherapy, then she can continue with the same antiepileptic drugs. Okay, and if she is not well controlled on that, we can change that after taking advice from the neurologist as well. Now, what is the prevalence of epilepsy? That is 0.5 to 1%. You have to remember this thing. Now, how is epilepsy diagnosed? How can we label that the woman has got epilepsy? The thing is that the diagnosis of the epilepsy and epileptic form seizure should be made by the medical practitioners with expertise in the epilepsy, usually neurologist. And women with a history of the epilepsy who are not considered to have high risk of unprovoked seizures can be managed as a low risk woman in pregnancy. Okay, and regarding the diagnosis, it's very important to know about the differential diagnosis as well. Okay, if the woman presents with the seizures in the second half of the pregnancy, the protocol of management should be same as for the preeclampsia. eclampsia. Okay, so after second trimester, if patient presents, then eclamptic protocol should be followed, and other cardiac, metabolic, intracranial conditions should also be considered in the differential diagnosis. Now coming to the different types of the epilepsy. Okay, the different types includes the tonic-clonic seizures, the absence seizures, juvenile myoclonic seizures, and focal seizures. Okay, the name are especially very important. You should have a little bit idea about what happens in that. In tonic-clonic seizures, there is a dramatic event of stiffening, bilateral jerkiness. Okay, in absence seizures, what happens that there are blank spells. Okay, patients becomes unconscious for a little bit time. And juvenile seizures, in which the jerks present as sudden and unpredictable movements and presents generalized seizures. Means focal seizures in which the specific part of the brain is affected, okay, and within an individual attack are recognizable and stereotypical, and seizures may impair consciousness, and primary focal seizures can undergo secondary generalization, and aura is the primary focal seizure. Now, how would we do pre-pregnancy counseling and management? Okay, counseling should be done in a proper way. Women should be informed about the risk to her and the risk of congenital anomalies in the baby. And there is also a possible risk of the long-term adverse effect on the neurodevelopment of the newborn. And women should be informed that in 2/3 of the cases, there will be no deterioration in the pregnancy. And how would you do the antenatal management? Okay, there should be a proper model for the antenatal care. The drugs should be regularly assessed by the clinician, and there should be proper routine antenatal care. Normally, scan should be done at the 18 to 20 weeks, and also the other biochemical screening with maternal alpha fetoprotein when combined with the ultrasound increased the detection rate of about 94 to 100% of the neural tube effect. Echocardiography at 20 weeks. Routine monitoring of antiepileptic drugs are not recommended. And healthcare professionals should keep an eye on the side effects of the anti-epileptic drugs, the adverse effects like as depression, anxiety, and neuropsychiatric symptoms in mother exposed to anti-epileptic drugs. And the healthcare profession needs to be aware of the small but significant increase in obstetric risks. And how should a woman be monitored? Women should be monitored for the risk factor of the seizures such as sleep deprivation, stress. Okay, and there should be a proper accommodation and environment that allow for the observation by the carer, partners, and nursing staff. And how should the fetus be monitored? Fetus should be monitored for detection of small for gestation age. Okay, and there is no role for antepartum fetus surveillance with CTG. And what is the optimum timing of delivery? Okay, about this it's written that there is no specific timing of the delivery. That depends upon the obstetric indications. Means cesarean section or the planned induction of the labor. That depends upon the cesarean. Depends upon the obstetric indications. Corticosteroid, the same dose is given if woman there is a chance of going in preterm labor. Now, how would you provide the intrapartum care? Okay, the woman with epilepsy should be concerned that the risk of the seizures in labor is low, and adequate analgesia and appropriate care in the labor should be provided to minimize the risk factors for seizures such as insomnia, stress, and dehydration. And long-acting benzodiazepines such as clobazam can be considered if there are high risk of the seizures in the peripartum period. Antiepileptic drugs intake should be continued during the labor. If this cannot be tolerated orally, parenteral alternative should be administered. And in the interpartum care, if the woman is at high risk of developing seizure, continuous fetal electronic fetal heart rate monitoring is recommended. Okay, so now how would you manage the status epilepticus, or if the woman develops the seizures in labor? In that case, lorazepam is given. The dose is very important, 0.1 milligram per kg, usually 4 milligram bolus, and a further dose of after 10 to 20 minutes is preferred. Diazepam 5 to 10 mg is administered slow intravenously as an alternative. Okay, and if there is no IV access, then it's very important to give diazepam of 10 to 20 mg rectally or 15 minutes later. Now, what are the methods of analgesia? Okay, about this it's written that pethidine should be avoided. We can give her the TENS, transcutaneous electrical nerve stimulation, nitric oxide, and intox and region analgesia. These can all be given. Now, coming to the postnatal periods, in that it would be better if we say that the woman should be advised to continue antiepileptic drugs postnatally, but she should be advised to be aware of the triggers, because there is increased chance of the seizures in the third day postpartum period, in the postpartum period. And antiepileptic drugs should be reviewed within 10 days of the delivery to avoid postpartum toxicity. Contraception, we have already discussed that first choice is IUCD, second Mirena, third Tempa. Okay, so thank you so much. These are some questions, and now it would be better if you read the whole guideline. Thank you so much for your patience.